So how many you have planned, Apurva, webinars?
Yes, ma'am.
Your target, how many webinars you have planned?
Ma'am, as much as we reach to each and every society.
We are live now.
Yeah.
So we are live now. We are good to go. So very good afternoon, all the respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I, Vasis Mehta, welcome you all for the COR Connect live webinar with DSOG Aesthetic and Sexual Medicine Committee in association with Agra, Bijnor, Bulandshahr, Hapur, Jhansi, Muzaffarnagar, Saharanpur OBGYN Society. And theme of today's webinar is on sexual health. So today I would like to welcome our convener and coordinator, Dr. Apurva Kumar Datta, sir. Sir actually needs no introduction. He is young, dynamic.
Vasis, it's okay. Thank you so much.
Thank you. Thank you so much, sir. Over to you, sir.
Yeah. Okay. Please. Good evening and welcome to all of you from the land of Bhagwan Birsa Munda, that is Jharkhand. So I welcome you all. Now, when we started, I started my journey in a sexual medicine committee. What I feel and what I see that we gynecologists are actually not much aware of about how to deal with the sexual problems, but we gynecologists are first source of contact when our patient has any problem. The friendly OB-GYNs are the first point of contact to whom they are coming and telling us their problems. So this is a sincere effort of on behalf of my society to reach each and every society, Foxy societies, and give the basic knowledge about the sexual health, about the sexual medicine, about the sexual problems, how to deal with them and how to treat them, so that we can, what happened, the patients are going to the quacks and they are misguided. So it is my sincere effort so that we can handle this and they give benefited from all of us. So as we all know, when we started something new, we always get the blessings from our seniors. Today is really, really a very special day for me, because today I have one of the tallest, I can say, not only in the Foxy, but all India, one of the most respectable person, and she doesn't need any introduction, the Padma Shri Dr. Usha Sharma ma'am. Sharma ma'am doesn't need any introduction. With her effort, government has given ma'am the 4th highest civilian award, that is the Padma Shri, for her tremendous effort for upliftment of the for the women health in our country. So ma'am, आपको कुछ बोलना, आपके सीवी के बारे में कुछ बोलना is like सूरज को दिया दिखाना है मैम. मैम, thank you so much for always being there. मैं जब भी आपसे मिलता हूँ, I'm always get motivated, always get, and I'm literally I'm saying ma'am is so busy, but जब भी even I got a message, ma'am is always reply me, beta क्या कर रहा है, कैसा है, how is all. Ma'am, thank you so much. We all youngsters, we all should learn from you. Ma'am, over to you, ma'am, for your blessings and for your words.
Thank you very much, my dear Apur. You are just like my son, and I'm really very proud of you, the way you are working for Foxy. And I'm sure all the youngsters today with me, I have got my very affectionate, beloved, dedicated, hardworking guest of honors, Dr. Ritu Khanna from Banaras. And we have got Richa Sharma from Delhi. And my dear, I can say everybody is like my daughter, पर निहारिका से मेरा खास रिश्ता है, क्योंकि I have been associated with her family for a very long time. So all the three beloved, affectionate, capable, confident, and I can always say hardworking guest of honors, and then convener and coordinator, my dear Apurva, whose efficiency, I think everyone who is here knows how efficient he is and how nicely he organizes everything. Then we have got Dr. Gayatri and Dr. Neha, from the office bearers from the Dhanbad Society, as well as we have got two very learned speakers, Dr. Poonam, who will be telling us about teenage pregnancy and POXO Act, and Dr. Madan, Kamla, who will be telling us about the sexuality and pregnancy. And then again, we are having a panel discussion, which is on female sexual dysfunction, which is moderated by our dear Apurva, and expert is Dr. Neeraj. All of us know that Dr. Neeraj has worked very, very nicely because still he is chairperson of Sexual Medicine Committee, and he has really contributed a lot towards this. One thing I will always say, that, and then I will not forget the representatives from COR Connect who have organized this, who have given all technical support for this webinar. All of us know that sexual or sexuality is a disease or is a problem which is seldom discussed in the society. It's very sad about it. In our era, you know, whenever there was such a problem, we just talk to it like a hush push attitude कि भाई चुपचाप से हम उससे कहते थे अच्छा तुम बताओ कान में क्या है तुम्हें problem, and then we used to think कि कोई तीसरा आदमी ना सुन ले. Not only the patient, but the doctor was also thinking कि कहीं तीसरा आदमी ना सुन ले. So this was the attitude long back. Gradually, with the liberalization and modernization, when we are having better knowledge about the sexual health, and then when we know that few things are very, very important for all of us to know about the sexual health. Reason why we are so much ignorant about it. आजकल भी अगर सच्ची पूछो तो ऑब्स्टेट्रिशियन गायनेकोलॉजी सेक्सुअल प्रॉब्लम से थोड़ा सा दूर भागते हैं. अरे भैया इसको रिफर कर दो, अरे उसको रिफर कर दो, क्योंकि कभी कभी हमको लगता है रीजन इज दैट वी हैव नॉट बीन एक्चुअली taught this sexual health, not in our MBBS curriculum as well as in our MD curriculum. And actually, that's why Apurva, you and Dr. Neeraj, I really congratulate you to organize this webinar of the Dhanbad Society in association with Agra, Bijnor, Bulandshahr, Hapur, Jhansi, Muzaffarnagar, and Saharanpur, because through these webinars, we can learn a lot about the sexual health. And then not only sexual health, the most important is the law which is related to sexual health, about which we are almost totally ignorant. So Apurva, I really congratulate you, and I'm sure the deliberation today will update the knowledge of each one of us, and these deliberations will certainly make us wiser and will make us more confident to deal with a patient of problems with the sexual health. I wish this program a great success, and thank you very much, Apurva and the whole team, for making me a part of such a prestigious program. I wish you all a very healthy, happy, and bright future. Thank you very much.
Thank you so much, ma'am. It's really correctly point out, and we are really blessed to have you and your words to us. Thank you, ma'am. Thank you so much. Thank you, ma'am. So after the blessings from chief guest, now we are getting blessings from guest of honor, and we have three very eminent, young, energetic, and really all of them are really my favorite. I always get inspired by the quality of work, by the hard work they are getting, and बहुत कोई मुझसे बोलते हैं कि you are so hardworking. From where you are getting all this energy? Now these are the people I am blessed to have seniors like them, जिसकी वजह से मुझे करने का प्रेरणा मिलता है ताकि मैं काम कर सकूं. So first is Dr. Ritu Khanna ma'am. Ma'am is just about to travel, and thank you so much, ma'am, that you are giving us the time and your blessings. Ma'am doesn't need any introduction. She is at present
Thank you.
the chairperson, Foxy Food, Drug and Medico Surgical Equipments Committee and whatnot. We always enjoy your company, ma'am. You are just has a
Thank you so
wonderful.
much.
You are Foxy in Varanasi, ma'am. We
Yes.
enjoyed a lot the Ganga
Yeah.
Aarti and all. Thank you so
Thank
much,
you.
ma'am, for coming. Over to you, ma'am, for your blessings.
Thank you so much, Apur, for inviting me for this great academic session. And I've texted to Apur, what is this DOGS? I thought it's a new,
I also
sexual
asked him.
and
He said Dhanbad
aesthetic
Society.
medicine. So he put it so beautifully, and that was Dhanbad Obstetric Gynae Society. So that's wonderful. I think you got a lot of innovative paths, Apur, and my gratitude to Padma Shri Usha Sharma, madam. And madam, we are really treasured to have your blessings. And I think every time we meet you, it's always a new inspiration for us. It goes as a new day for us. And that's why we really love you having you with us. So thank you so much. And a special thanks to the president, Dr. Gayatri Singh, and the secretary, Dr. Neha. They're so vibrant and dynamic. And of course, I don't know how they do their meetings and everything. You really love to be with them. And my very dear and loving friends, Dr. Niharika and Richa, it's always a pleasure to share the sessions with you, and we always love, and we were working together.
मेरा फोन का है
And the selected
देख नीचे
topics
तो
that
नहीं
we've
रह गया
chosen,
बाकियों को mute कर
for the
दो, please.
presentation. And we have, I think they are the apt speakers that you've taken. Dr. Parul and Dr. Badan Kamble, I think they're going to do real justice, and we really come out with so many things. And the moderation, of course, you yourself and Dr. Neeraj, I think Apurva and you and Dr. Neeraj have really given a new turn, a new face to this committee. We were not aware of that. There's so much to do into it. So let's see, I think you're going to take it to newer heights. And of course, we are very happy to see our chairpersons. Neeta Sharma, madam, it's always a pleasure to meet you anytime. Dr. Poonam and Dr. Rekha, and fantastic panelists that you've taken for your panel. Asha Mishra, madam, Manju Prabhakar, ma'am, and Manju Gupta and Jitendra and Dr. Lubika. So I think it's going to be an exclusive session, and all our best wishes to all of you, Apurv, Dr. Neeraj, and of course, UP, our heart, and all the societies. I think the societies we love, Agra, Bijnor, Bulandshahr, Hapur, Jhansi, and Muzaffarnagar, Sarapur. I think we're so well connected with them. We feel, like there are so many connected, so we are all connected. So thank you so much, and best wishes to all of you once again. Thank you so much.
Thank you. Thank you so much, ma'am. Thank you so much, ma'am, for your always blessings and your timing. Thank you so much, ma'am. Thank you, ma'am. So the next is Dr. Niharika, ma'am. Again, doesn't need any introduction. My friend, my senior, my guide, and whatnot. I always, feel very humbled and always enjoy the company of Niharika, ma'am. We बहुत सारे हम लोग जो वो चिट चैट करते हैं about the Foxy with the young, we all youngsters. It's really a wonderful. And yesterday we had a wonderful webinars with the Young Talent Promotion Committee along with the Sexual Medicine Committee. Ma'am, thank you so much for always your blessings, for always your guidance, for always your advice. She doesn't need any introduction. Ma'am is at present the chairperson of the Young Talent Promotion Committee. She is the एक senior IVF consultant at Rainbow Hospital, Agra, and whatnot. A lot of contribution in the chapter and a lot of awards in her credit. So thank you so much, ma'am, for coming and joining us. Over to you, ma'am, for your kind words.
Thank you so much, Apurva. And today is such a special day. I have been upgraded from being an MOC to a guest of honor, madam. So this is my first webinar as a guest of honor, and I'm feeling so honored कि आप बड़े हो गए हैं.
Niharika, congratulations. Good.
And ma'am, past 3 years, I've been working with the Young Talent Promotion Committee. When I started this journey, I did not know what I'll be doing. And today, when I look back at my journey, I can say that last year, 3 people from the YTP committee became chairpersons of Foxy. This year, 5 people from the YTP committee are standing for elections for chairperson. So my committee is growing and glowing all around. And I feel immensely proud that yes, I am grooming them the right way. They're understanding how Foxy is and how Foxy is growing. And Apurva is one of them. From the start of my committee, he was my first member in those 40 members. Then he shifted to the sexual medicine committee. Neeraj sir ne snatch kar liya. But we have done a lot of events together, Apurva, and I'm sure you're going to rise and shine very brightly. I feel so happy today that we are at a stage where we understand these small topics need so much importance. Instead of going to the regular topics, we have to talk about things which are not being discussed openly. And these webinars are actually a blessing in disguise for all of us, because we are sitting at our home and actually spreading knowledge and awareness all around. So congratulations to the Sexual Medicine Committee and the UP team and Dhanbad Society for bringing in today's webinar. And in the end, I'll just say a small quote, and I feel we all should take something back, saying that this planet actually doesn't need successful people now. Our planet now really needs healers, restorers, storytellers, and peacemakers. And that's what we all have to be. We have to be healers first and then climb the success stairs. So all the best to all of you, and thank you for having me here.
Thank you so much, ma'am. And yesterday there was a one phrase of yours, and I really, it was a wonderful that why not we are as a influencer, we are doing so much for the committee, you know, we are much for the our community and for the people of this country. So why they took their influencer as who are not actually the influencer, and we who are doing actually from the ground level work, we should be the influencer to the common people of our country. So it was really a wonderful praise by you yesterday, ma'am. Thank you so much for always your coming, for always your blessings. So next is Dr. Richa Sharma, ma'am. She again doesn't need any introduction. She is a wonderful academician. I always love listen from her lectures, and thank you so much, ma'am. She always guide me. She always advise me and what not. She doesn't need any introduction. Ma'am is the professor at UCMS Delhi. Ma'am is the chairperson of the Foxy MTP committee 2021 to 24. A lot of, in total, more than 15 awards in her credits, and lots of, you know, she is even now she is presenting the papers. So ma'am, it's wonderful. She is always being in research, and you are an ideal and inspiration for all of us. Thank you so much, ma'am, for giving us the time. Over to you, ma'am, for your blessings. Richa, ma'am.
Thank you, Dr. Apurva, for such a nice introduction. A very good evening, everybody. And first of all, my regards to the chief guest, respected Dr. Usha Sharma, madam, and other guest of honors, Dr. Ritu Khanna and Dr. Niharika. And my regards to all the seniors, colleagues, and the delegates from Agra, Bijnor, Bulandshahr, Hapur, Jhansi, Muzaffarnagar, Dhanbad societies, and Saharanpur societies. And I must congratulate you, Dr. Apurva. You are doing a fantastic work with Dr. Neeraj Jadhav, who is the chairperson of Sexual Health Committee, Foxy. And you have organized such a nice webinar, because I feel the topic which have been chosen, in fact, the entire committee, Sexual Health Committee, is something which is not really talked about, and there are a lot of gray areas. So you have chosen nice topics, and I can see there are so many eminent faculties are also there who can really do justice with the topic. And so I think everybody is waiting for the scientific session to start. So let me not stand in between all these things. But I must once again congratulate you, Dr. Apurva, and wish you all the success for this webinar and all your future endeavors. Thank you so much.
Thank you. Thank you so much, ma'am, for giving your time and for being with us. Thank you so much. So with the permission from our chief guest and guest of honor, now we will start our scientific session. And our first session is a very controversial topic, and teenage pregnancy and POSCO Act. Why I am telling it's a controversial? Because even like I am from a very small city, Dhanbad. So many times the patients are coming with us and the pregnancy of 18-year-old. So, and it is, they are married, they are coming with the husband, with the families. So we are always, in a confusion, in a state of confusion, what to do. What are the complications which might be having in the teenage pregnancy, and what in a POXO Act, what we should do. So for the chairing the session, we have a three eminent chairperson with us, Dr. Sushma Gupta ma'am, Dr. Deepika Goyal ma'am, and Dr. Pramila Mita ma'am. Sushma ma'am doesn't need any introduction. She is at present the president of Agra OG Society. She is the director of Akanksha Test Tube Baby Center, Agra, consultant at Dr. Kushum Gupta Nursing Home, and a senior gynecologist in Agra, practicing from last 25 years.
Join.
Our next the next chairperson is Dr. Deepika ma'am. Ma'am is the MBBS DGO consultant at Nidan Nursing Home, Hapur, working since last 30 members, associated with the FOXY, ISOPAS, Menopause Society, IMA, and whatnot. Thank you so much, ma'am, for coming and giving us the time. Our next chairperson is Dr. Pramila Mita ma'am. Ma'am is again a senior gynecologist from Bulandsahar. She is at present the president of the Bulandsahar OB Society. Thank you so much to all the chairperson, and I'd like to invite Sushma Gupta ma'am to please introduce our first speaker, a very dear friend as he and colleague of mine, Dr. Parul Sauji. Yeah, over to you, Sushma ma'am.
Thank you so much, Dr. Apurva. That it's a pleasure being here with you on this. And this topic is definitely very well, it should be learned. And today it is the need of the day. Am I audible, Dr. Apurva?
Yes, ma'am. You are absolutely audible. Yeah.
So I have the pleasure of introducing Dr. Parul Sauji. She is affiliated and she is the executive director, Omega Hospital. She has specialized in aesthetic gynecology. She's a consultant and an infertility specialist and a laparoscopic surgeon. She's president of JCI Nagpur Medicos. She's member of AMOGS, NOGS. She's the winner of many awards such as AMWI Golden Jubilee Award. She's winner of Dr. Chaitanya Shem Baker Gold Medal in Infertility. She's the winner of Yuva Gold Medal at Nagpur OBGY Society. She has been a faculty at many conferences. She's the author of many chapters in books on infertility. And also she is also a co-author. She's a well-read, very good academician and a perfect person to give this talk. So over to you, Dr. Parul. Please start.
Thank you, ma'am. Thank you, Apurva sir, to just give me this opportunity to have myself here in front of all of you. Thank you, the chief guest. She is a dear ma'am, and she needs no introduction. And without any ado, I would be very thankful for the societies who have been in association with sir. And I would like to share my screen. So very good afternoon to one and all. Up sabhi ne, I'm sure each one of us have been through that phase during our teenage, and we have seen this movie, which is done by a very dynamic and a very pretty lady called as Preeti Zinta. All of us know this actress, and this movie then had created a lot of humble and fumble because it was about her pregnancy during her teenage when she was in school, when she was in college, sorry. So that's Preeti Zinta. We have seen one more movie, which is Tere Sang, when the girl who was just 15 and the boyfriend is 17 and she conceives and the struggles which she goes through. So here we are discussing about teenage pregnancy and POXO Act today. So myself, Dr. Parul Sauji, I would be taking you through this teenage pregnancy and the POXO Act. So 11% of the world's teenage pregnancies happens to be in India, which is quite a huge number, which makes it 16 million women. Let me repeat it, 16 million women between the ages of 15 to 19 who became mother each year. Aren't you shocked? It's a huge and a humongous number. So what exactly is teenage pregnancy? As defined by the American Pregnancy Association, it is a pregnancy that occurs for a woman under the age of 20. And according to United Nations Children Fund, it is a pregnancy which happens in girls with prevalence in these teenage pregnancies. First of all, it is the law enforcement which hesitates to get involved. We all know that the age for marriage for women and for the girls in India is 18 years. But the law also hesitates, largely because this early marriage is sanctioned by the culture and the social norm. Living in rural areas is one more factor which contributes to such a thing. Not attending school, especially for the girls, is something which is also a contributory factor for this genesis, a rise and high prevalence of teenage pregnancies. Whenever a girl starts their periods, the potential to be married and bear children takes primacy. Then no longer it is important that she would want to go to school, she want to take up higher education. All what is the concern is that she should be married away. Financial considerations. That is also one of the factors which play a very important role when it comes to early marriages. Dowry demands and suitability issues increases with age. That is why many parents, they just have the idea in their head that they should get their daughters married away at an earlier age so that the dowry demands are lesser and also they can find a suitable match for their daughters. Considering the financial issue, there's one more thing which comes into picture, that many parents, they think that if they have two daughters, they can get them married away in the single mandap so that the finances can be curbed and in a single mandap, both of them can get married. So this reduces the cost of multiple weddings. We have seen this movie Dhadak, which is one very big example of honor killing. So they're married early as families worry they could engage in romantic relationships, bringing dishonor. So this is also one of the reasons why early marriages take place and resulting in teenage pregnancies. These days, exposure to media is at a very, very earlier age. So there is no filtration of obscene contents. They see heroes, heroines do it, and so they want to do it also. Another contributory factor is drinking and smoking. Abuse of drugs makes men and the children and the adolescents of that age lose conscious of what's right and what's wrong. And that also is one of the factors which would lead to increase in the number of teenage pregnancies. Other than that, lack of supportive parents and family, the child is deprived of love and he or she looks for pleasure and happiness elsewhere, unaware of the consequences of the same. Exposure to sexual violence. There's a lot of sexual abuse which we encounter at home, around home, unhealthy environment, in and around home, and also sexual violence when it comes to other people. Stressful lifestyle is one more contributory factors because a depressive lifestyle can always lead an individual to look out for something in which they will find momentary pleasure. Awareness. That is a very, very, very important thing, that there is no awareness in our teens about contraception. Very rightly said by one of the seniors right now, that we never knew that sexual medicine is such a thing. As Usha ma'am said, that, we, like ma'am is saying that earlier people used to whisper, even the gynecologist used to whisper in the ears of the patient. Similarly, this problem of contraception is not something which is discussed very openly in schools, in colleges, with parents, and that is why it is resulting in a lot of these teenagers landing up in pregnancies because they are unaware about contraception. Lack of communication between parents and adolescents about sexual and reproductive health issues, and the educational level of teenagers. Again, coming down to the same, that how safe it is to have sex, what is the right age of having sexual contact, and if at all they're indulging into something like this, what all contraception is something which they should be using. Little access to correct and comprehensive information on family planning and access to contraceptives, whether married or not, is also something which should be taken into consideration, because if they have the right access, if they have the right information, probably we can curb on the number of, teenage pregnancies which are happening. Needless to say, Indian societies are still a lot of patriarchy is involved. So wives have too little to say in the number, timing, and spacing of the children. So I feel women empowerment is also something which, Indian government is working on, a lot of societies are working on, we as gynecologists are working on. And if, the women get the right to decide on the number, the timing, spacing, use of contraception, there would be lesser number of teenage pregnancies. Coming on to the impact of these teenage pregnancies. We all know when a woman conceives at an earlier age, at teenage age, there is a higher rate of pregnancy-related complications like anemia, hypertension, hemorrhage, and unsafe abortions also come into picture. Malnutrition, sexually transmitted infections, again because these teenagers are unaware about the contraception, early exposure to sexual contact leading to, again, cervical cancers, multiple partners leading to all these things, and psychological issues are also highly prevalent. So how to prevent it? Over past decade, India has successfully reduced the proportion of pregnancy between 15 to 19 years to half. So through mass awareness and legislation, India is trying to mitigate the burden of early marriages and hence teenage pregnancies. In addition, adolescent girls are being introduced to basic knowledge of menstrual health as a sincere effort to come out of social taboos. With the introduction of peer educators, India is expecting to bridge this gap and address a sensitive social and medical issue like teenage pregnancies. So providing general health education about risk of teenage pregnancies, strictly enforcing the minimum age at marriage law, screening all pregnant mothers for all the risk factors, providing at-risk mothers with education about childbearing and rearing, and referral to a hospital for safe delivery. Referrals are particularly important among first pregnancies among women under 18 years old with multiple risk factors. So a lot of things are being done, a lot of things are taken care, a lot of acts are taken into implementation which are helping India curb this teenage pregnancy ratio. So children and mothers do not just have consequences for the mothers and the newborns, but have a huge ranging implication for our society and our economy. And as gynecologists, we have a lot to take care when it comes to any of this by educating and spreading awareness. Coming to the POCSO Act. What exactly is this POCSO Act? The Protection of Children from Sexual Offences Act. And it came into force with effect from 14th November 2012. So what is it? The POCSO Act 2012 defines a child as any person below the age of 18 years and provides protection to all the children under the age of 18 years from sexual abuse. It also intends to protect the children through all stages of judicial process and gives paramount importance to the principle of best interest of child. Where all it is implicated and applicable, it is applicable in whole India except Jammu and Kashmir. So the offenses which are covered in this act are penetrative sexual assault, aggravated penetrative sexual assault, aggravated sexual assault, sexual harassment, using child for pornographic purpose, and trafficking of child for sexual purposes. All these have stringent punishments, like penetrative sexual assault has a punishment of 3 to 5 years, and along with that, fine. When it comes to aggravated sexual assault, the punishment which is a maximum term of rigorous imprisonment for life and fine. When it is the sexual harassment, it is minimum of 5 to maximum of 7 years of imprisonment and fine. And when it comes to using child for pornographic purpose, the offense is with maximum term of 5 years along with fine. So now whom to report? Special Juvenile Police Unit or local police and Child Welfare Committee are the centers where we have to be reporting for any such act which comes into our knowledge. Is it mandatory to inform police? Yes. The Section 19 POCSO Act, Section 357C, both instruct the doctor and hospital to mandatorily inform police, even if she's married and under the age of 18 years. Section 21 POCSO Act and Section 166B IPC prescribe punishment for not following the direction of Section 19 POCSO Act. That is 6 months of imprisonment along with the fine. So the reality is that early marriage and consequently pregnancy is most often not the result of a deliberate choice, but the absence of choices and of circumstances beyond a girl's control. It is a consequence of little or no access to school, employment, reliable information about healthcare, and poor utilization of health services and patriarchy and forced sexual contact. So we as gynecologists should be spreading awareness so that we can curtail onto the rise of teenage pregnancies and stop these teenage pregnancies. So that would
thank
be
you so much. Yeah, thank you so much, Dr. Parul, for really a wonderful lecture. It is really an eye-opener for all of us. I would like to take comments from the chairperson, Deepsika ma'am.
Yes. Good afternoon, everybody. The reasons Dr. Parul enumerated are very realistic in Indian scenario. To prevent teenage pregnancies, sexual education as well as moral education, that they should not involve in sexual relationship. The teenagers, the teenagers should not involve in sexual relationship, for which they should be educated with sex education and moral education. What type of moral education? They should actually, our teenagers are nowadays are very explore करने के उसमें रहते हैं कि we should, जो उनको मना किया जाए, they want to explore that. तो उनको ये समझाना चाहिए हमें साइंटिफिक तरीके से कि भाई आप ये सब अवॉइड इसलिए करें क्योंकि आपकी सेक्सुअल, मेंटल, फिजिकल हेल्थ पर जो है बैड इफेक्ट डालेगा अगर आप इस तरीके के एक्ट्स में इन्वॉल्व रहते हो. That is my message, and thank you, Dr. Parul, and
thank you.
Thank you. Thank you so much, ma'am. Pramila ma'am.
Hello.
Pramila ma'am. I think ma'am was there. Okay. Susma ma'am.
Yes, I wanted to just add one word that we should teach all our daughters, our teenagers, to respect their body, to respect themselves, and not allow it to be the playground for every friend or acquaintance that the girls meet. That they should respect their body, they should respect themselves, and they should keep their body safe away from roving eyes. They should be able to do that. They should be able to say no. That is what I would like to say here. And I think it was a very great talk. And we can now, Dr. Apurva, we can now move on to the next one, if you.
Yeah. So before that, yeah, ma'am. Pramila ma'am is there. Ma'am, you have to unmute
Dr. Parul,
yourself.
very nicely, you have covered the topic, POCSO Act also, and then how to prevent it. Just want to ask 2 questions. Now, if a teenage pregnant girl comes to you, they are married, okay, teenage. One girl is 16 years, for example, and the boy is major, and they are married, and she has come for an ANC to you.
Hello.
will be your
Ma'am,
plan
is it audible to me?
as
Yeah, Richa ma'am, your voice is
gynecologist?
actually break.
Okay,
There is
that
some
is one
issue in
thing.
the connection.
And
Yeah. Richa ma'am, your voice is not at all audible.
Acha. Am I audible
Uh,
now?
yeah,
Yes,
ma'am. Now you're
come.
audible. Yes, ma'am. Please,
Okay.
ma'am. Yeah.
Okay. So, okay, so I was not audible. So, Parul very nicely covered the topic, everything. Just two things I want to ask. Now, a pregnant girl who is a minor, okay, the couple has come for antenatal checkup. Okay. So, as a gynecologist, what will be your plan of action? Okay. And if a couple comes, for example, a boyfriend and a girlfriend, and they want termination of pregnancy, then what will be your plan of action?
Ma'am, if the couple who has come is below the age of 18, I would like them to get a guardian or somebody so that we can take this further. And when it is coming to the pregnancy, and if a couple has come and if the wife is less than 18 years of age, as per the law, we should be informing, because any, even if it is a married act and through which a girl has become pregnant, we should be informing the police about such a thing. And second of all, we should be guiding them that now when she is conceived and they're already married, so how should they take it further, and the next one should be at a proper spacing, and whatever the high risks are involved, we should be guiding
Okay,
them.
that is fine for this particular, she has come for ANC, you will inform the police. The next moment they will start, creating a scene, why police and things like that. They are happy in the married life. Okay, and it is like in India, it is very common, no? You get a teenage
Yes, ma'am.
pregnancy. So I just wanted to give a message through this. Now, what I ask is basically when you inform the police, okay, as a gynecologist, you are making the MLCs, okay, medical legal certificate,
Yes,
you are making, you are informing the police by whatever method, take the receiving signature, everything, keep it for your medical legal safety because the POSCO says so. But don't insist for the FIR, okay, and tell them also that informing the police doesn't mean FIR. It is just that we are making a MLC, informing to the higher authorities like it is a medical legal case, but we are not insisting for FIR. Take the informed refusal, written informed refusal of FIR in the case sheet for your safety. So you have to tell them like informing the police is just a formality. It is a part of your working because the law says so. MLC and FIR both are different. MLC is just a medical legal case recording, but FIR means a complaint is lodged and then the investigation, court case, and the punishment. So both things are different. So before we inform the police, okay, in such cases, we should always tell the couple or the relative, everybody, that it is just a normal, working of our as a gynecologist. Otherwise, they start, getting so worried why police and things like that, and at times they start beating up also the doctors. There are few incidences. So before you approach the police, before you call, you take them into confidence and then just make the MLC. Don't record the FIR. So that is one thing. And same goes with if a couple, they come with a consensual sex and they want the MTP out of that, same thing. You make the MLC, inform the police, take the signatures or whatever from the police, but don't lodge the FIR, okay? But take the informed refusal for FIR for your safety. So that is very important. Thank you.
Thank you. Thank you so much, ma'am, for really a practical and wonderful inputs. Yeah. And Pramila ma'am is there. Ma'am, you have to unmute yourself. Pramila ma'am, आप प्लीज अनम्यूट कीजिए. आपकी आवाज नहीं आ रही है मैम.
Hello?
Yeah, ma'am. Now, yes, ma'am. Now you're audible.
I'm
Yes,
audible?
ma'am.
Yes.
Yes,
Thank
ma'am,
you,
you are
Dr.
audible.
Thank you, Dr. Parul. You delivered a very precise, nice, and informative talk. And I wanted to say only two things. There should be a good bonding between the child and parents at the home about the sex education, and in the school between the teachers and the students. There should be a good bonding between the two about the sex education. And the second thing is, we should educate our rural parents not to go for the early marriages before 18. That means before 18. If after 18, the girl is married or the boy is married, then the pregnancy will happen after 19 or 20. So more of the complication will be solved. Thank you. Thank you so much.
Thank you. Thank you so much, ma'am. Thank you so much, Dr. Parul, for the wonderful deliberation and all the chairperson for being with us. And thank you so much, Richa ma'am. It is really an icing on the cake to have your inputs, very practical and to the point. Thank you so much. So we're moving to our next lecture. And for chairing the session, we have a very three eminent chairperson with us, Dr. Neeta Sarma ma'am, Dr. Poonam Yadav ma'am, and Dr. Rekha Singh ma'am. Dr. Neeta Sarma ma'am, can I have yeah. Yeah, Dr. Neeta Sarma ma'am is postgraduate and graduate from the Kanpur, director and senior consultant at Koti Gate, Hapur. And working since last 31 years. He is at being the president of the Hapur OB Society, secretary of the women's wings of the Hapur, secretary of the Mission Pink Health, that is from IMA at the Hapur, received women empowerment about twice in her. Thank you so much, ma'am, for being us and for giving us the time. We have the next
Thank you.
Dr. Poonam Yadav, ma'am. Ma'am is at present the secretary of the Agra Society. Ma'am has a lot of achievements and awards in her credits, like Foxy Korean Awards in a senior category as well as junior category, Dr. DC Datta Prize, Dr. Jagdishwari Mishra Prize for Best Prepper. She is being a guest speaker, moderator, and panelist at a various national and international conferences. Thank you so much, ma'am, for being with us and for your blessings. The next is Dr. Rekha Singh, ma'am. Ma'am is MBBS from Meerut, DGO from KGMC, senior residency from Delhi, trained in laparoscopy, held office of secretary of the Muzaffarpur branch for 2 years. She is delivering lecture in multiple CMEs and participate in online COVID awareness activity with Abhi Vera Foundation. Thank you so much, ma'am, for coming and giving us the time. So I would like to invite Dr. Neeta Sarma ma'am to introduce the next speaker, Dr. Madan Kamble sir, and the topic is sexuality and the pregnancy. Over to you, Dr. Neeta Sarma ma'am.
Thank you, Dr. Apu. Thank you so much for inviting me. Good evening to all of you. It's my proud privilege to be here and introduce esteemed speaker, consultant OBGYN and aesthetic gynecologist, Dr. Kamble Madan sir. Sir, he's a chairperson from AMOG's Aesthetic and Sexual Medicine Committee. 2022 to 2024, he is past secretary and president from AKLUG OBGY Society. Akluz, sorry. Akluz OBGY Society. And he is member of Foxy Sexual Medicine Committee, Council of Sex Education and Parenthood International. Actually, it was not in my CV when I saw his CV. He's an organizing chairperson from AMOG's Journal Conference on Sexual Medicine, ACLUS 2021. Sir, we know lots about sir. He is a very good speaker. So I invite him for his lecture for the pregnancy and sexuality. So I would like to say 2 words. Marital success and failure may be related to sexual satisfaction. Pregnancy represents a life crisis to the pregnant woman and her husband. Complex psychosocial, physiological demands and may produce insecurities, anxieties, and somatic complaints. Sex is considered safe during all stages of low-risk pregnancy. Sex during pregnancy is a great way to stay mentally, emotionally, and physically connected. So with this, I would like to hand over to Madan sir. It's over to you, sir. We are eager to listen to you, sir. Thank you. You are welcome, sir.
Thank you, Neeta ma'am, for so kind introduction. Thank you, Apurva. And thank you, Dhanbad Society and all associated societies of UP, and for arranging such a wonderful webinar today. Yeah. Is it visible?
Yes, it's visible. Please make it full screen, sir.
Okay. Yeah. Good evening, all. Today we will be discussing one important topic, which is very useful for our day-to-day clinical practice of OBGYN. Yeah. हर स्त्री के भीतर दो स्त्री है, एक वो जिसे तुम देखते हो और एक वो जिसे तुम समझ नहीं पाते. तो आज बस इसी स्त्री को हमें समझना है. Woman is God gifted for her ability to produce another life from within. There is no alternative to the love and affection a mother showers on her child. Before the baby is born, she carries the child under her heart. And from the moment it is born, she always carries the baby in her heart. And pregnancy is the only state in the life of a woman which takes her life a completely new role, which is totally irreversible. And one thing is always certain, that her life will be never the same again, because there are a lot of changes occurring. And the last 9 months of pregnancy, 10 to 20 hours of labor, and countless weeks of midnight feeds are really crucial for her. She may need 6 weeks to few months to regain her physical, mental, and sexual status to normal. What is important is feeling emotionally ready, physically comfortable, and relaxed. Let us discuss about what are the effects of pregnancy on sex. And depending upon the trimesters, in the first trimester or in the early pregnancy, there is always a fear of danger to the fetus, risk of bleeding or abortion, fear of vaginal trauma or infection. And in the late pregnancy, there is always the risk of PV bleeding or leaking, preterm labor, vaginal trauma, patient discomfort and anxiety is there. There is always more risk in high-risk cases like previous LSAS and placenta previa. The most important aspect of pregnancy is the postpartum period, because there are a lot of changes occurring. There is diminished or absent sex drive due to the hormonal changes. There is a lack of time for intimacy. Always there is lack of privacy due to small house or large families there. And mother is always, many times she is tired or exhausted due to the baby care. She may think of a risk of injury to the uterus or vagina in case of operative vaginal delivery or cesarean cases. There may be PV bleeding or lochia, sore breasts, patient's prolonged stay at mother's place leading to sexual abstinence. There may be vaginal drainage due to the hormonal changes. There may be physical and mental fatigue, depression, lack of sleep sleep and mood. There is always fear of unwanted pregnancy. There is low self-esteem, low self-confidence. She may think of her image is disfigured. She's not looking so attractive as she was before. She has to give more attention to the baby more than the husband. And many times she is confused by her new role as a mother. Always there is fear of waking the baby. And sometimes there may be mental harassment of her by the family members after giving birth to female babies successively, leading to marital disharmony. And the last thing, again, her anxiety over parenting. It is also affecting her sexual life. Then how is the libido pattern during pregnancy? How it changes? In first trimester, there is nausea, fatigue, breast tenderness that may reduce her sex drive. On the contrary, in the second trimester, libido may be high because there is increased blood flow and increased attraction to their pregnant partner due to the changes in the body shape. And in the third trimester, sex may be somewhat uncomfortable as the birth approaches. Then what are the benefits of sex during pregnancy? There is better orgasm due to the increased blood flow to the genitals. It keeps both the partners fit, fresh, and active. It increases bonding between both partners. And there is increased happiness. Then there are so many questions in her mind. Is the sex safe during pregnancy, and what to do, what not to do? And will it cause a miscarriage? Will it harm my baby? Or are there any sex positions to avoid and to prefer? There are so many questions in her mind. But actually what happens, we don't give much time to them in our OPD. Actually, we should advise all these things antenatally by taking 5 minutes extra in the OPD. Then when to avoid sex. There are the cases which are at risk of miscarriage, or if there is any past history of miscarriage, or at risk of preterm labor, or if there is past history of same, or in patient with PV bleeding or leaking, or there is excessive vaginal discharge. In cases of placental malpositions, multiple pregnancy, IVF conception, or prolonged infertility. Such cases are high risk and better to avoid the sex during pregnancy. Then what are the positions during pregnancy which are considered more safe? This is classic missionary position. Second is the modified missionary position. Doggy style is there, scissors, spooning position is there, side saddle, and woman on top. Basically, the purpose behind this is there should not be pressure on her pregnant belly. That is the purpose. That is why the woman on top and doggy style, and these positions are considered more safe, or modified missionary. There should not be any pressure on the pregnant abdomen. What if the woman don't want to have sex? There is more to intimacy than sex. They can share their needs and concerns with the partner in an open and loving way. They can try for cuddling, kissing, or massage. They can enjoy masturbation also. These are the alternatives when they don't want to have sex. Then what are the special precautions which are to be taken? They can use the barrier contraceptives to prevent the STDs like herpes, gonorrhea, etc. Then positions which are comfortable and stimulating to both, they should be adopted. They should avoid the lying flat on back for sex after 4th month. Doggy position is always better. They can use the lubricant if there is vaginal dryness. Oral sex is not contraindicated, but it should be with proper hygiene and precautions. Anal sex, it will not harm the baby, but it may become uncomfortable if the woman has pregnancy-related hemorrhoids. Avoid anal sex followed by vaginal sex to avoid the spread of infections. There are also other ways of intimacy. If you are not going for sex, cuddling, kissing, or massage, they can enjoy the bubble bath together also. Then about supportive care. They should, that pregnant lady should have healthy and balanced diet. She can have her routine exercises and for fitness. And try to work out a goal and get your partner involved. Give compliments to the pregnant partner that she is so beautiful and attractive. It definitely boosts her fragile self-esteem. They can get out of the home for a trip. And advice to the husband is to be patient, and advice to wife, show attention to your husband. Having children is an amazing blessing. Life is full of sacrifices, but the rewards are much more greater. A great feeling of seeing your wife in action as a mother and working you alongside as a dad. And even though your sexual calendar is empty for a while, your new role will keep you too busy and fulfilled. In many cases, there is no risk of sex during pregnancy, but they should be careful. Some positions are more comfortable in pregnancy. Sex drive may wax or wane during pregnancy, and couples need to communicate clearly about their desires. This can help both the partners to enjoy the sex throughout the life. Thank you all.
Thank you so much, Madan sir. It's really a topic because we as a gynecologist, a lot of time patients are coming with us, the pregnant lady, whether it's a safe to have a pregnant sexual intercourse in the pregnancy or not. So you have given a really a beautiful insight in a very precise manner what to do. So I would like to invite the chairpersons, Ma'am Poonam Yadav, ma'am, your comments, please.
Thanks and congratulations to Dr. Apurv for making me part of this webinar and taking such a less talk topic, I should say. And topic is very well taken up by Dr. Madan, and every point has been mentioned in his talk. Few things I want to add: just pregnancy is a long journey of 9 months, and it's the responsibility of a responsibility of us that to counsel couple regarding their queries of the sex, because many couple are asking in our day-to-day practices, as it should be individualized. It cannot be generalized, as pregnancy related problems and complications are different to different women, so that it should be individualized. And we must counsel husband all the husband should be well informed about the mental as well as the physical status of a wife, so that she can respect her decision at any time, and must educate regarding the safe sex practices. I think these things I just want to add. Otherwise, overall, the webinar is going very well.
Thank you so much, Poonam ma'am. Yeah, really, you have told this very nicely. Yes, it should be individualized. It should not be generalized to every patient. Thank you, ma'am. Rekha ma'am is there. Rekha ma'am. Ma'am, you have to unmute yourself. Rekha ma'am, please unmute yourself. Yeah, ma'am.
Thank you, sir. First, you have cleared so much about the physical as well as mental level of pregnancy, at the level of pregnancy. The topic is very clear, and this is most common questions asked by husband about the sex, and you have cleared so much and very informative talk about the sex in pregnancy. Very good.
Thank you so much, Rekha ma'am. Thank you so much. Neeta ma'am, your comments, please.
Yes, sir. You have described everything in a very nicely or in a very detailed way. The main one thing I would like to say is open communication will be the key to a satisfying and safe sexual relationship during pregnancy. Whether this means talking about how you feel, trying different positions, or finding other ways to be intimate, as Dr. has already explained. So I will say key communication is a very important thing. Loving, tender care, along with this sex should be there. Thank you.
Yes, thank you, ma'am. You have rightly pointed out. Yes, thank you.
Thank you so much. So thank you so much, Madan sir, for really bringing out this very important topic in a very precise manner. And thank you so much to the chairperson for chairing the session so beautifully. Now, it's the time to our last session for today. And the last session is the panel discussion regarding, the female sexual dysfunction. So I just wanted to say one thing. Our expert is Neeraj Jadhav sir. Sir doesn't need any introduction, and he is my sir. Neeraj sir is my mentor. Whatever I am in sexual medicine and whatever I know little about the sexual medicine is all due to Neeraj Jadhav sir. He is unfortunately in some emergency. Will be joining in shortly, and I have a wonderful panelist with me. So the first is the Asa Mishra ma'am. Ma'am doesn't need any introduction. A very respected name in Uttar Pradesh and around area. And ma'am is so active even at this age. Ma'am is the professor emeritus and former head of the department of Obs and Gynae at National Capital Institute of Medical Science and Hospital Meerut. Ma'am is the patron and the past president of the Hapurovia Society. She being the chaired more than 100 sessions and being associated with and attended more than 100 national and international conferences, have a clinical experience of more than 45 years. Thank you so much, ma'am, for being with us and agree to be part of this webinar. Thank you so much.
Next, thank you so much.
Next, Dr. Manju Prabhakar, ma'am. Ma'am is associate professor of Muzaffarnagar Medical College, and but unfortunately, due to some emergency, she has to leave, and she will not be joining. Dr. Manju Gupta, ma'am. Ma'am is MBBS DGO, working at the Raman Hospital, Bulandshahr, UP. And thank you so much, ma'am, for joining. The next is my very dear friend and junior, Dr. Jitender Behra. He is from Bhubaneswar. He is stuck in and In an OT, he will be joining shortly. Next is Dr. Lipika. Yes, again, she is a very upcoming consultant, IVF specialist from Odisha, from Bhubaneswar, and being a diploma in sexual health and subspecialty and member of the National ISHAR Sexual Medicine Committee and whatnot, have a lot of award in her credit. Thank you so much to all of you. So I just need to share my screen. Sorry. Is visible?
Yeah.
Yeah. Okay. Madan sir, I just request you because since Neeraj sir is not here, so can you take up as an expert, and whenever I ask, I will advise you to please give your comments. Okay.
Okay.
So my dear friends, we are celebrating 75 years of independence, the Azadi Ka Amrit Mahotsav. So let's take a pledge so that we give our women, the women of India, free from the disharmony, the pain and suffering due to the sexual dysfunction. Now, this is the message which I want to give before I start. Now, what is sexual health? When we're talking about the sexual health, it is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health required a positive and respectful approach to sexuality and sexual relationship, as well as the possibility of having pleasurable and safe sexual experience free of coercion, discrimination, and violence. For sexual health to be attended and maintained, the sexual right of a woman or all the peoples must be respected, protected, and fulfilled according to WHO. Now, what is the female sexual dysfunction? The female sexual dysfunction implies persistent or recurrent problems encountered in one or more of the stages of sexual response. It is not the dysfunction unless the woman is distressed about it or it's negatively affect the relationship. Now, what is this means? This means that suppose that it cause a interpersonal disturbance or distress or depression in a woman when due to the sexual dysfunction, we call it as a disease or deformity or dysfunction. Now, before we learn that what is all about the sexual dysfunction, we should know what is the sexual response cycle. So, Asa ma'am, can you just please elaborate shortly what is the sexual response cycle?
Sure. Outset, I really thank you, Apurva, for making me part of this untouched topic. Thank you so much. So first of all, I would like to redefine the definition of FST. Since the development of DSM-5 in 2013, it is diagnosed, it is defined. Now it includes the female sexual interest and arousal disorder, female orgasmic disorders, genitourinary pain, and penetration disorders that could be primary or that could be secondary. And these symptoms must cause distress and must occur at least 75% of the time over a period of 6 months. So regarding the sexual response cycle, it has various phases, which are affected by the emotional, neurovascular, endocrine, psychosocial response, and all of which they can overlap. Female arousal and orgasm depends on the cognitive, emotional, and behavioral aspects that is different from the male arousal, which is more physiological. Now, phases could be enumerated as the phase of desire, arousal, intromission, orgasm, and resolution. See, desire is like excitement. It increases heart rate, respiratory rate, genital and facial vasocongestion, contraction of vulvovaginal and perineal muscles. And then comes the arousal, that is plateau. The same changes persist, but there's lubrication, orgasm, that is a climax, that is release of built-up tension, and there's a culmination of repeated involuntary perineal muscles contractions. That is orgasm after the vaginal penetration. And the resolution is the muscle relaxation. Body slowly returns to the baseline form of the unexcited state. There is no refractory phase in women, and they can experience repeated and multiple orgasms if sufficiently stimulated.
Very rightly said, ma'am. And really, you gave all the insight of about what is female sexual dysfunction and what is the cause. Thank you so much, ma'am. For the audience, I just wanted to just give it is a 2-line that there are the 4 stages, you can say, in a response cycle: the desire, the arousal, intromission, and orgasm and resolution. So any problem in any of these, stages cause the disorder, and accordingly, if there is a problem in the desire disorder, then we call it as a desire disorder. If there is a problem in the arousal, we call it a arousal disorder. If there is a problem in the orgasm, we call it as an orgasm dysfunction. So it is as simple, 4 stages of the response cycle, and any problem in that, it causes the deformity. And sorry. So ma'am has rightly, now there is a 2 models. I am not going to tell, but Master and Johnson model, which is, the linear model is there. There is one more, the circular, that it's contain the excitement, plateau, orgasm, resolution. Not going to detail, but there is a 2 type of model. The Master Johnson is a circular, and Master Johnson is the linear model, and another model is the circular model.
Bason's model.
Yeah, Bason's model. So accordingly, classification, ma'am has already stated DSM-5 classification. There is a problem in the interest and arousal. It's the sexual interest or arousal disorder, or there is a orgasm disorder. Is the orgasm disorder, or if there is a third is the genitopelvic pain penetration disorder. So first, I just wanted to, what are the, before take one, the causes one by one, just overall, what are the causes of the female sexual dysfunction? Now, I think Manju ma'am has yet to join. Madan sir, can you just please enumerate what are the causes of the female sexual dysfunction?
Actually, broadly, it can be divided into non-organic causes and organic causes. Non-organic, maybe there are so many entities which are related to social factors, cultural factors, and psychological factors. But organic causes are very much important. That may be developmental, medical, surgical, drug-related. And also, there are so many myths and conceptions, stress-related, then communication problem. There may be performance anxiety, negative attitude, and disturbed interpersonal relationships. And again, most important is the male sexual dysfunction that can surely affect the female sex or sexual activities.
Dr. Apurva, can I just add something?
Yeah, definitely.
Thank you so much, Dr. Apurva, for this opportunity. This topic is actually very close to my heart because I've been practicing exclusively infertility. And I think 80% of subfertile couples have this issue, but they are reluctant to talk about it openly because of the social stigma associated with it. So it's our duty as clinicians to incite them to talk about their issues. One of the workshops I had attended, actually most of us do not ask because we do not know what to do with the issue. If the patient and couple opens up also what to do further with the issue to help the couple, we are not actually very much aware of this because it's a huge branch. There have been great people who are working exclusively on sexual medicine and all, but it's just our minor responsibility to start learning step by step about sexual medicine. So I just wanted to add a few causes of sexual dysfunction in another way. It could be, the causes could be remote or it could be immediate causes. Remote as in some past psychological trauma, some past childhood trauma, or some past childhood sexual abuse, which has negatively impacted the idea about sexuality. That is one. And immediate factors could be some domestic violence or some partner related issues, some distress in the personal, interpersonal relationships that could also contribute to female sexual dysfunction.
Absolutely, absolutely correct, madam. And many times, yes, very correctly, when we are taking detailed history, I think in majority of the time, 70% of the time, there is some, some sexual abuse in the past. So
Yeah.
very correctly point out by the Lipika ma'am. And Madan sir, just you have tell it beautifully about the male sexual dysfunction. Many a time we are just came patient females coming with the sexual dysfunction. We are forget to the talk about the male sexual dysfunction. Like many times there is a arousal interest disorder. It is actually secondary to the male sexual dysfunction. So it is very important to talk about or ask about and taking history about the male sexual dysfunction. Next, what is the effect of the sexual dysfunction? Jitender, are you there, Dr. Jitender?
Yeah, I am there. Okay.
Yeah.
So
Just, yeah,
thank you,
please,
Apurva sir.
yeah.
Actually, it's my first topic related to sexual dysfunction. This is my first panel in my career. So anyway, thanks for the opportunity and really excited to be part of this. So as you know, that effect of sexual dysfunction, it will affect both male and female. Okay. So once it will happen, so first of all, one will feel the low, means inferiority, like those so low self-esteem will be there, and there will be frustration. So once the frustration will develop, they may go for there will be anxiety, then depression, unhappiness, irritability. Then as a result, there will be quarreling, arguments, and the interpersonal relationship also it will get disturbed day by day, even if it is in office or even if in the family members. And finally, it will happen with the marital disharmony. Then they will come to the doctor as an infertility, and even also after the counseling, it was a proper counseling. If it is not happening properly, so definitely it will be ended in a divorce.
Absolutely, very correctly point out. Many a time everybody, many time people are advise me, why you take this branch or this committee? Why not? Because people are concerned about maternal mortality, about the other things, the infertility, the laparoscopy and all. But I am saying this is really a silent pandemic. And what we are seeing actually the tip of the iceberg. So it is the high time we should take note of all this, and we should learn about things, and we should treat our patient accordingly. Very correctly point out.
Dormant volcano.
Yeah, absolutely, absolutely perfect.
And it is applicable to us also. It is also applicable to us
also.
Yeah.
Absolutely. And wonderful quote by Asa ma'am. Yeah, it's an erupting volcano. We will take the first cause, the type, the female sexual interest arousal disorder. Now, Dr. Lipika, what is about this female sexual interest arousal disorder? And when we called it is, I mean to say, what is the criteria of diagnosis this?
Yeah. So basically, according to the new guidelines, 3 out of any of the 6, as the name itself suggests, that it's hypoactive desire. So there will be either absent or decreased sexual interest in and erotic thoughts or fantasies. Apart from that, new criteria have been added on 4 additional aspects of sex life, that is absent or decreased initiation of sexual activity or responsiveness to a partner's attempt to initiate it, or a reduction of the excitement and pleasure during the sexual activity, which could be situational, suggestive of a specific situation, or it could be generalized, like happens all the time in different situations. Or there could be a decrease in arousal in response to sexual clues, whether it's written or verbal or visual, and also reduction of sensations during sexual activity, whether it's genital or non-genital stimulation. What is more important is that these sort of symptoms need to be present in at least 75% of the incidences, and for a persistent for at least a period of 6 months. And the patient or the couple both should be in distress. They should be seeking medical help. So that is female sexual interest arousal disorder. And moreover, non-sexual causes like mental disorders and domestic violence or drug abuse, that should be ruled out before labeling it as a female sexual interest arousal disorder.
Yeah, just one more thing. This experience at least 75 to 100% of the time, and minimum duration should be 6 months. It's not like that. I'm telling you one thing. Many times, the first night failure, people are unable to perform the first night, and they come to the clinic directly on the very next day and saying, oh, he or she doesn't have the interest. So it's not like that is single time. Arey bhai, शादी के बाद सबको थके हुए होते हैं. They want to take sleep and everything. We Indian have so much rituals from the morning to night. So like that, it's not. It should be at least minimum period of the 6 months. Then we label it as a disorder and dysfunction. Yeah. Next is how to evaluate it. Ma'am, Asha ma'am. Yeah. Suppose that when you diagnosed, yes, it is a case of female sexual interest arousal disorder, then how will you evaluate this case?
Yes, HSDD is a low sexual desire and associated with distress. It's very common. It is unaddressed. It is untreated disorder, has a negative impact on the health and the quality of women. Firstly, it is necessary to gain the patient's confidence, make a rapport, so she is able to disclose her problem. A few brief questions could determine whether further evaluation for the HSDD is warranted or not. Just for example, are you sexually active? If not, why? What are your sexual concerns? How do you feel about your level of sexual desire, arousal, and orgasm? Once the HSDD is a concern, for further evaluation is needed. And a decreased sexual desire screener that contains the 5 items validated questionnaire is given to her. If she circles yes on 1 to 4, no on 1 to 5, then there is probability she has a generalized acquired HSSD, and she should be then visit the specialist either, or otherwise also as a part, like we have an obstetric history, gynae history. Why a sexual history with a personal history is not a part of history taking for all general practitioners. And I think it should be inculcated in the curriculum, or it should be started with right from the history taking. So we are able to deal with the problem before it becomes too much. That's why the screening for it can easily be performed as a part of the office visit. Now, next step includes soliciting more details information from patient about their experience of low desire, onset, duration, behavioral adaptation, and avoidance, and the level of distress. Close evaluation of the patient's medical history, reproductive history, comorbidities like endocrinal problem, neurological, cardiovascular, psychiatric illnesses should be taken. Use of prescription or any using over-the-counter medication. A targeted physical examination according to history should be taken to rule out any other cause of low desire. Psychiatric disorders like depression and anxiety, they can be considered as a differential diagnosis. History of prolonged OC pills can be typical. Lab tests are usually limited, not required. According to the history physical examination, few tests can be taken if there's a thyroid, diabetes, or any other disorders. So patient has to be evaluated very thoroughly, and the history and taking the patient into the confidence is the key to the success of the diagnosis of HSDD.
Absolutely, ma'am. Absolutely. Thank you so much, ma'am, for bringing out each and every point, A to Z of the evaluation. Now, the problem with we gynecologists are now, we have to look after our OPDs. We have to look after our operations. We have to do laparoscopy. We have to do operations. We
I
have to
know,
attend the
definitely. As
webinar.
we
We have
take
to
a
go.
history, we take obstetric history,
Yes.
we take menstrual history, a personal history, only sexual history, quietly in
Sexual
one
history.
word. Are you sexually active? Nowadays, the girls are very open, I find. Huh? Unmarried
Yeah,
girls
yeah,
coming, and
absolutely.
I ask, they are.
Yes,
It's just
absolutely.
1 minute, few seconds time, but it should be
Time.
taken as priority.
Priority. Yeah, absolutely point out, ma'am. So we gynecologists have to take the history. Now, what I feel in OPD when I am seeing these cases, now this is very personal thing, and people are actually not open up very easily. And so we have to take patience, eye to eye contact. We have to, the environment should be like that. The no other patient, take one patient at a time. Then only able to they discuss about the things about their very personal issue. So history actually do at least 60 to 70% job done by the history only. The rest, as ma'am has already stated, we have to take the again investigations, certain investigations, thyroid, prolactin. We have to evaluate about the cardiovascular, the neurological factors, the diabetes, and these we have to evaluate. Now, after
Apurva sir, I have
detailed
one doubt.
evaluation, yeah. Yes,
Actually,
sir, please.
when we will if you want to reveal this kind of history, and when the couple are coming to the OPD, whether we should ask like male separately and female separately, what you feel, what is your experience?
Yes.
Now, what I am doing, I have a set questionnaire. I'm also getting it from my, and this is the female alag se and male alag se. Before coming to my lecture, my cabin, they are already filled it, and it's like yes, no, yes, no, yes, no. So when I have getting a few ideas. First, we have to take history from the male, then again separately to the female, and we have to ask them that whatever detail you are giving, I am neither right on the paper, and I will not discuss to your partner, not disclose to your partner. Then only they are very much open up to you. You have to just build a rapport with your patient. Then only they will speak up. And with that, I am taking you many a time. It will take 25 to 30 minutes to take a detailed history of male and female individually and combine. So this is the main thing. In these cases, we have to give time. Then only the patients are open up. So this is the thing. Now, after that, we are coming to the management.
Dr. Apurva, I would just like to add something. People who are
sure.
exclusively practicing sexual medicine, whenever they come for giving a talk or on a webinar, they always say ki itna lamba hai history taking if you're actually taking proper sexual history. Because it's so long, if you want to actually elicit their sexual issues from them, it's actually a very big concern and it's extensive. The sexual history taking charts are actually very comprehensive. So one thing we can do is, out of the 7 days of OPD, I think one evening can be placed for a sexual medicine OPD separately, where we call such patients, if you're not exclusively practicing infertility, because it's very comprehensive. And there are several tools also to take history.
Yeah, absolutely. Very correctly point out. What I am doing, and I have a separate OPD like in the evening, 1.5 hours for those patients, because in between the obstetric patient, you can't, mix up those. Because they are, अरे sir, क्या कर रहे हैं? 1 घंटा तक उसी पे बैठे हुए हैं. So they really don't like that. So this is one thing. Yeah, absolutely correctly.
But 1 minute history will segregate them, and then you can ask them to come for a different.
Absolutely, ma'am. Absolutely, ma'am. So about the management, Dr. Lipika, please go ahead.
Yeah, as far as most of the medical disorders are concerned, we actually start with counseling. I think counseling is a major part. It's now should be included in medical textbook, because counseling cures half of the issues. As far as I am concerned, I see a lot of PCO patients. So I think counseling takes me 45 minutes per PCO patient. Even same for sexual medicine. So first is obviously counseling, wherein we actually talk to the couple together or separately if they wish so. And we talk about the vulval vaginal hygiene. That's very important. We talk about the partner involvement, because I think this is only one issue where partner involvement is the major factor where as far as the treatment of the sexual disorder is concerned. So that is very important. And we should ask them that, I had read somewhere, I think in one of the talks, Narayan Reddy sir had told that sex is not about having two bodies aligned together. It's about your entire love life and interpersonal relationship. So that is what needs to be counseled, and counseling is the most important cornerstone of management. Following that, we move on to psychotherapy. Like we always believe, what doesn't matter to the mind actually doesn't matter. So if we make things big, it becomes big. If we consider it a small problem, it will be cured. So psychotherapy, like sensate focus therapy, cognitive behavioral therapy, mindfulness, like being attentive while talking to each other, partner involvement, and there are few OPD tools which need to be used while managing the psychotherapy and counseling, like Plicit, which is we take permission from the couple, we provide them with information, limited information, we suggest them what they should be doing, and then we focus on the therapy related to the particular concern. The next model is allow, which is we ask the couple what is their problem, we legitimize the problem, and we say that okay, that is a problem and we need to address that, we need to talk over that. Then we need to tell them the limitations of the problem, and they need to open up their problems entirely before us, and then we work together towards solving the problem. And another tool is MEBIS, wherein we approach the mind, emotions, body energy, and the spirit of the entire couple or single partner as such. Now, as far as the psychotherapy is concerned, there is a sensate focus therapy, and this therapy is almost used for most of the sexual disorders. This is basically based on like touching and stimulating non-sexual organs first to derive pleasure, and then gradually moving on to the sexual organs so that they build a rapport before actually going into having sex directly. So that is sensate focus therapy. And there is a cognitive behavioral therapy where we counsel the couple that you start deriving pleasure from non-sexual acts. That's very important, like fondling or listening to each other, understanding each other. So that is very important. So you try to derive pleasure and fondling from non-sexual activities, not in sexual form, and then move on to the sexual activity gradually. So this is what is cognitive behavioral therapy. And as far as pharmacotherapy is concerned, there is a newer drug which has come up, that is flibanserin. It is actually a serotonin receptor modulator. It plays an agonist in certain parts and it plays an antagonist in certain parts. And it reduces the serotonin drive in the prefrontal cortex. So that is how it helps, and it's useful in most of the FSDs. It works, its results are seen in an approximate period of say 4 weeks. But if it doesn't show any result within 6 to 12 weeks, we need to stop the drug. So that's what usually I don't know whether this drug is available in India or not, but it has come up in textbooks. So then testosterone is one such drug, like 0.1 to 0.2% of the drug can be used in the form of gel or cream. And it's a drug which is essential for sex drive in both the sexes, in both the genders, both for male and female. Although the threshold level of testosterone, the serum level of testosterone that is required for female sexual drive is lower compared to males. And even other drugs like buspirone and bremelanotide, DHEAS, sildenafil, that is a nitric oxide donor, which is a vasodilator, and that way it increases blood flow to the sexual organs, and therefore it improves arousal and desire.
Yeah, very correctly point out. I just want briefly about the what to do and what is the management. Absolutely correctly told by Lipika. That the counseling part is the best. You have to do counseling. Many times I am telling you about the interest arousal. I have one couple just trying to have the story, and after 15 days of marriage, the couple came to me, and what happened during their marriage, there is some dowry issue, and there is a big fight between the in-laws and between मतलब सास ससुर में और उसमें हुआ था. So this got a very bad and negative effect on the female, and that's why she doesn't have the interest to go with her husband. So many times this is a small history out there, and you have to take out the history, what is the cause of that, and we have to give counseling, and after giving the counseling, when those tits bits and those misconceptions are gone, then actually they are able to perform. First thing. The secondly, the psychotherapy about the sunset focus, Lipika has absolutely correctly said. I'm just giving it is in 30 seconds. First, I told patients, bhai, just talk each other. Hi, how are you? How was your day? हाँ, कैसा हुआ आपका? Just do like it for 2 weeks. 2 हफ्ते तक आप ऐसे करो. Then second, हाँ, आप second हफ्ते क्या करो? 2 हफ्ते के बाद, oh wow, today your dress was so good. है ना, your hairs are so good. अच्छा है ना, बहुत अच्छा लग रहा हो. चलो, go के आते हैं. So like from formal to have a specific. The third time have some wow, your body is so good. You have something like you have to do step by step. The fourth step is the having the curdling, the the sex with the clothes on. You have don't remove the clothes, you have the curdle itself, hug itself, kiss itself, and finally it is the penetrative intercourse. Now these are the 5 stages of the sunset focus, and correctly point out, Lipika, that almost in every cases, in cases of female sexual dysfunction, we have to use, and it is a really wonderful. About the mindfulness, I just wanted to tell what happened. What is mindfulness? Mindfulness means when you are entering into your bedroom, just leave everything outside your bedroom. लीव एवरीथिंग. भाई आज बॉस ने ये बोला था, अरे आज घर में ऐसा हुआ था, आज पेशेंट पार्टी ऐसा बोल के गया, यार आज उसका आईवीएफ फेलियर हो गया. You have to leave everything in outside your bedroom. So and don't, I always I tell my patient, don't put the Hanuman ji in your bedroom. भैया हनुमान जी जहाँ होने चाहिए पूजा घर में रखो. You can have the Sunny Leone photograph in your bedroom, but don't put Hanuman ji's photo in your bedroom. It should be like you and your wife, and leave everything. Third thing which I always used to tell, especially the tech guy, when the husband wife both are working, they are working, came late, and they are really exhausted. So I always advise her to perform in the morning, not in the night. Because in the early morning, in 6, 7 o'clock before they wake up, it's really had a wonderful, things, and they are really energetic. So these are the few practical tips which I want to give. And so pharmacotherapy, which I am using, and freely I advise everything, it is testosterone gel. It's freely available everywhere. I used it up to 6 months a month, and it is a wonderful result. Second, DHEA. What is actually dose of DHEA for interest arousal disorder is 100 milligram. But we don't have 100 milligram in our, it's a 75 milligram, but I am using it 75 milligram. It has a wonderful effect in a perimenopausal lady. Sildenafil citrate, again, 25 milligram OD for 3 months, wonderful effect. But the problem with the sildenafil is, it causes the blue vision, and it's called the headache. So this is one thing which is actually, but these 3 I am using, and it has a wonderful results. Now coming to our next, the female orgasm disorder.
Sir,
and what is
testosterone gel, what is the dose, and what is how used to applicate, anything? Just
it
can you give the idea?
like, I think you are an IVF specialist. You are using testosterone gel. You just
No, we are
pinch
using
of
for
it.
IVF people, but I just asking about the
It's a 0.1 to 0.2 gel are there, and you have to just pinch of it. And people are actually thinking, now we have to apply it over the perineum. No, you apply everywhere, even in the hands, anywhere. You just apply it,
especially non-hairy area.
Non-hairy area. Yeah, it should be in the non-hairy area. Apply it, and it has a wonderful results. That is the thing. Now coming to female orgasm disorder, Madan sir. So Manji ma'am is not there. Yeah, can you just have defined what is female orgasm disorder? Please, sir, go ahead.
Yeah, again, the criteria we are using is DSM-5, and actually, according to it, the delayed, infrequent, or absent orgasm, or markedly decreased intensity of orgasm after a normal sexual arousal phase on all or almost all occasions. And again, there is distress or interpersonal problems due to orgasmic dysfunction. And along with it, there is no other disorder or substance that exclusively accounts for the orgasmic dysfunction. And again, all the symptoms or dysfunction must be more than 6 months. These are the main criteria to define an orgasmic disorder.
Absolutely, absolutely correctly said. It should be either of the less than 6. This would be either 6 or more than 6. Then we call it a orgasm disorder. Ma'am, Asha ma'am, what are the types? Different types.
Usually there are 4 types of female orgasm disorders. First is the primary, that is the lifelong anorgasmia. That means a lady has never experienced the orgasm. Second is the secondary anorgasmia, that is the acquired one. She had experienced orgasm before, but for last few, sometimes she is finding some problems in facing the orgasm. There could be generalized FOD, that is refers to inability to orgasm with any partner or any situation. And then could be situational FOD, that refers to inability to orgasm with only in specific situation and with certain partners only. So there are 4 types of FODs.
Absolutely, absolutely, ma'am. So primary, secondary, ma'am has given it very beautifully, situational and generalized. So first we have the definition, we have the type. Now coming to the management, Dr. Jitendra.
So management, actually, there is 2 types. One is behavior therapy, and then we can go to the pharmacotherapy. So regarding the behavior therapy, we can go for direct masturbation. Then already Deepika has already explained about the regarding the censored focus therapy, and also sir has also told regarding the mindfulness. So those are the things has to be maintained, and relaxation technique, like now how the somebody will be relaxed. So they should be follow the same technique how to relax yourself, and sex enhancement technique, like already sex therapy which is available, that education should be treated properly, and systemic desensitizations.
Absolutely correct. Now, before I just wanted to go to next, what is direct masturbation? Now, direct masturbation is first we have to understand what is orgasm. So to have that, we are actually ask our patient to have the masturbation so they can have what is actually the orgasm. Then only when we are saying that yes, this we are achieving this goal. When we have certain goal, then we are achieving this goal. We ask our patient to have the masturbation so that they have an idea what is orgasm. Then only we can just ask them. So this is what is the direct masturbation. Senses focused, sex therapy and techniques, it's beautifully explained by Jitendra. And it is almost the same in every cases of the female sexual dysfunction. Now, what are the medicines, Dr. Lipika, which we are using?
Like we have already discussed, I think most of the desire, interest, arousal, orgasmic disorders in female are all interlinked, and the therapeutic approaches as far as drugs are concerned or counseling or psychotherapy is concerned are also similar, most of them. So yes, vasoactive drugs like PD5 inhibitors like sildenafil, as you told sir, 25 milligram once daily. Ideally for IVF and all, we use it vaginally because of the blue vision and head reeling that you told, headache happens orally in few people, not in all. So that increases lubrication by increasing blood flow to the local area, to the clitoris and genitals and all. As far as hormones are concerned, in perimenopausal age group, most of the women complain in perimenopause especially, they complain of vaginal dryness and painful intercourse. So their estrogen cream applied locally, that can also help. Or 0.1% of 2 milligram estradiol tablets can also help, or hormone replacement therapies or tibolone, which are selective estrogen receptor modulators, that can also help. And like we have discussed, testosterone increases, improves interest, arousal, as well as helps in orgasmic disorders. And DHEA 75 milligram once daily, that helps, especially in again perimenopausal age group. As far as nutraceuticals are concerned, yohimbine and some over-the-counter products, nutritional supplements, lot of other professionals, non-medicos, they are very much aware of these nutraceuticals, and over-the-counter drugs are manufactured and sold off much more than the therapeutic drugs, medical drugs. So these are also available for the orgasmic disorders.
Yeah.
What
What
about
I see,
yoga and
yeah,
acupuncture?
ma'am.
I've learned somewhere acupuncture and yoga, they are trying for.
Yes, ma'am. That was mentioned actually in the relaxation techniques by Dr. Jitendra. So that is yoga meditation will go under like just being more mindful and stress free. So any therapy which reduces our stress will always improve any sort of sexual dysfunction.
Absolutely, ma'am. So actually it was na like bhaiya dawa kaam kare, dua kaam kare, kuch bhi kaam kare, it the patient should be benefited. So
Exactly.
and what about
तुम्हारा
the
जिसमें इंटरेस्ट है उसमें
nutraceuticals?
जाओ.
उसमें जाओ. About nutraceuticals, actually what I am using in few cases, it has some role. At least psychologically, it has role.
Yeah.
Few are definitely are good antioxidant and it increases the blood flow. But but psychologically, yes. In many lot of patients get benefited. They are like, भैया हम लोग कुछ दवाई ले रहे हैं, and so हमें अच्छा ये benefit करेगा. So these are the thing. But yeah, definitely these are not approved by FDA. That is the main thing.
And we come to know that such drugs exist from patients. They say that ये ले रहा हूँ, ये काम कर रहा है sir.
Actually. So we are coming to the third very important topic, and we are going it a little bit fast because we are running short in time. The vaginismus. So, ma'am, Asha ma'am, can you just elaborate what is the vaginismus? Sorry.
Yes.
Yeah, ma'am. Yeah, you can
So
pick
it
up
can
or
be earlier definition was recurrent and persistent involuntary spasm or constriction of the perineal musculature surrounding the vaginal outlet and outer 1/3 the vagina that interferes with the vaginal penetration. So it is first time it was described by the J. Marison Sims in 1862 as reflex-like contraction of the circumvaginal musculature resulting in the consummation of the marriage. So recent definition, which is given by the International Society Committee in 2005, vaginismus indicates the persistent and recurrent difficulties of the woman to all type of vaginal entry of a penis, a finger, or any object, despite the woman's expressed wish to do so. So this can be defined like this.
Absolutely, ma'am. Very truly said. And
So
it is
it
very
can be
important, and it is.
it can be of two types. Primary, that is a lifelong. That means the first time, whether she puts a tampon or it is the first time of the intercourse, the penetration is not possible, or it could be secondary, that develops after a person had already experienced sexual function, but not or is able to procreate or perform the sexual function. It could be global, that could be primary, secondary. Global means the symptoms occur in response to any penetration. And it could be situational, that could be primary or secondary too. Vaginismus that occur in response to some type of penetration.
Absolutely,
So it is
ma'am.
a 4 type.
Ma'am, can you? Yeah, great. Yes, ma'am.
And it can be graded 5. There were initially 4 grades by Lemont 78, and the 5th grade is recently been added. The first is the mildest form of the vaginismus. The spasm of levator ani is there, but after counseling, reassurance, the pelvic examination can be possible because the patient will relax. The second grade would be the spasm of levator ani persist. She is unable to relax, but still the pelvic examination, the vaginal examination can be done. And the third grade, the patient avoids totally examination. She elevates buttocks and does not does not support the examination. And the fourth is the patient elevates the buttock, retracts, adducts her thighs with dorsal arching, bending forward, and avoids the examination. And fifth grade, that is the PASIC added another grade of vaginismus. Patients with grade 5 vaginismus manifested by the visceral response such as crying, shaking, trembling, sweating, hyperventilating, experience palpitation, fainting, nausea, vomiting, going unconscious, wanting to jump out of the table, and ultimately she want to attack on the doctor as well. So these are the fifth grade of the severity of the vaginismus.
Absolutely, absolutely. Wonderfully, beautifully explained by ma'am. So after diagnosis and grading, now it's the time to for the treatment. Dr. Jitendra, please can you enumerate what the treatment options are available? Yeah.
Yeah, these are the patients, sets of patients is very like I think counseling is the major role to solve maximum of their issue, because properly the sex education should be given properly. So first thing is that you have to assure the patient that the treatments are available. It's not like that she will have permanently like this and she will have bad sexual life. So first thing, you have to assure the patient, you have to make the patient in comfortable position so that she will be thinking of something like what you say, some hope in the future, and address the medical condition of the patient or to the couple. And sex education, it is very highly essential. So you can, just like I have seen that people will complain that they will have dry sex, or sometimes they will just jumping on for the sex only. But I don't think that is the proper way. They can go for foreplay and then followed by just go after that they can go for intercourse. So these are the things can be taught properly. And like if there are nowadays some pelvic floor exercises also available, because I have seen one video that some people are applying some castor oil for the relaxation of the levator hernia and all, but I don't know how far it is really fruitful. We have to take some patient and apply on that, and then can come to the conclusion. So that is one therapy, like pelvic floor exercises and some systemic vaginal desensitization like dilators, fingers, or some special instrument which will help in dilating. So that can be used. Then pharmacotherapy, definitely these patients need some anxiolytics, so you have to go for it. And always in any organism, whether it is orgasm disorder or any female sexual dysfunction or vaso, you have to go for these two things. One is psychotherapy, and second thing is cognitive therapy and sensate focus. So I think these are the main three elements, whatever the treatment option in any kind of female sexual dysfunction. So these three things has to be applied properly. And nowadays the Botox treatment has also come. So I think these are the treatment options for the vaginismus.
Yeah, absolutely correctly point out. And it is not only the pharmacotherapy or the dietotherapy, but counseling and sex education. Because many a time people are so much, they never seen their, the sexual organ. They never seen. They don't have any idea of their anatomy. So the teach the anatomy that it should be like that. It is very important. And all the therapy should be go hand in hand. It's not like that we are directly jump into the pharmacotherapy or dilator therapy. The counseling, sexual education is again very important. Now the recent advances is
like to add something, Dr. Apurva.
Yeah.
I think self-exploration, like you said, they're not aware of the female anatomy itself. So that's where a mirror therapy, a simple mirror for self-exploration of the genitals, that works wonders, because they never know where to have relations, which is the urethra, which is the clitoris, which is the vagina. They're not aware of that. So simple mirror therapy can help them exploring their genital organs, understanding the anatomy before actually getting into this. So it's a part of exploration, self-exploration.
Absolutely, ma'am. Very truly said. Now, the recent advances is the Botox. Dr. Lipika, have you ever used it or any experience of having the Botox?
I haven't used it, but I am aware that there are commercial vaginismus kits available. Why is it called systematic? Because we move from low caliber dilators or cones to high caliber. And why is it called desensitization? Because the levator tone and the pubococcygis entire complex, the inherent muscle tone is high. So that is why it's called systematic vaginal desensitization. There are cones and dilators available, and this should be combined definitely with sex education, self-exploration, sensate focus therapy, psychotherapy and all. This is not something to start with. So you start with all that mindfulness and all that we have discussed, sir, and then we move on to this. And each dilator and dilators are available in different sizes from 19 to 35. And each dilator progressively increasing calibers should be placed in the vagina for a minimum of 10 to 15 minutes for that to work, for the dilator or the cone to help in relaxation of the muscles. Otherwise, it doesn't work. And first with self fingers and then moving on to the partner's fingers. And that too from the little finger moving on to the like wider caliber fingers.
Absolutely, absolutely. So actually, these dilator should be individualized. Like it should be used in a one patient, and it is freely available Amazon and everywhere. And it is not available. It is so we actually ask them to bring their own dilators. It is always advisable to do that. Now coming to Botox, sir, Madan sir, just
Yes.
have you ever used it, or what's your opinion about this Botox, Madan sir?
Practically, actually, I have not used it, but as per the recent literature, there is definitely a role of Botox, which is very much emerging. It is very useful.
Actually, initially Botox will be used for that beautification, but now
I've seen that.
Now it's a beautification of the vaginal rejuvenation. I have used in one patient. Actually, it is provided by some pharma. A pre-filled syringe is there, and actually, it is very easy to use it. But what I feel, very less number of patients are actually need this Botox. At least 90 or more than 90% of the patients having vaginismus can be treated by systemic desensitization, by therapy and all. So actually, these are the pre-filled, and these are the preferable sites. And our sites, we should be away from the 6 o'clock and 12 o'clock to avoid the incontinence. And these are the points. It should be like 3, 4 and 5 o'clock, and it should be like 8, 9 or 10 o'clock position, so that it is used. And it can be used, but I have worked in one, and it's work. Those who are using the cosmetic gynecologists, they are using it readily, and it's actually work what they are telling. Dr. Lipika, your comments?
I haven't used Botox, but my husband is a dermat, so he has used for anti-aging therapy and all, and it's being very rampantly used for cosmetic gynecology as well. But we should be very careful, and more than 2 sessions are usually not advised. Like one injection session of Botox that's effective, the effect starts within a week, and it lasts for around like 6 to 7 months. So I think repeat sessions for that is not very advisable, Botox.
Very advisable. Absolutely, absolutely. So we will come to the last, and very quickly we take this very important topic, that dyspareunia. Ma'am, Asha ma'am, can you just please enumerate it? What is actually the dyspareunia definition?
The Diagnostic and Statistical Manual of Mental Disorder 5, that is MSD5 I've been talking about, defines dyspareunia as a sexual pain disorder, a subcategory of sexual dysfunction. The pain must be persistent or recurrent and cause marked distress or interpersonal difficulties. The integrated pain model emphasizes that the physical and psychological factor may be instigating causes and reason for perpetuation of the symptoms. As many as 60% of the women experience dyspareunia when defined as pain with intercourse.
Absolutely. This is the dyspareunia. The treatment, before we go into treatment, we have to understand and we have to rule out the other organic causes. The most common is the PID. Now, still it is very common, and many time, the PID, and if it is a deep endometriosis, many time dyspareunia is actually an indicator that might be sees a case of, endometriosis. So we have to rule out these two. And literally nowadays, the ultrasound is very good, TVS ultrasound, to rule out the endometriosis. We have to rule out endometriosis. We have to rule out the PID, or we have to, if you don't want to give the ultrasound, you just give one course of, antibiotics. And if the patient relieve, that means it's a PID. It's a cause is organic. If it is not, then we have to, the treatment option is the psychotherapy and medications. So, Dr. Jitender, and anything what you want to give in this case of patient where it is a non-organic causes, organic you have rule out. When it's a non-organic causes, what the treatment option you have, Dr. Jitender?
Yeah, you can go for moisturizer or some lubricants. And nowadays, some people, they are telling that. Hello?
Yes, please go ahead.
Yeah. And some people, they are telling that you can use coconut oil. I don't know how much it is applicable. You can just share your experience. Okay. And
many times actually, I am telling you, they don't find anything, so they are using coconut oil and they are satisfied with that. And they told me, yes, many of our patients are, they don't have anything, any moisturizer, anything. They thought that coconut oil is the very good moisturizer, and actually it has a very good moisturizer.
It has
So they are
anti-allergic
using
property also. So
yeah.
most of them.
And it's a
and
freely available everywhere.
Also. Petroleum jelly.
Yeah, definitely. So absolutely correctly told, the estrogen, even in case of perimenopausal or menopausal ladies, Tibolon can be used orally. In case of menopausal, perimenopausal, it increases, the hormone level, and definitely it's being a good options for the medications. The newer techniques, Dr. Lipika, any idea? You have to unmute yourself, Dr. Lipika. Please unmute yourself.
Yeah, as far as moisturizers are concerned, like simple calamine lotion and all, they have a ability to, they have a adsorbent ability, so they retain water, especially dryness in perimenopausal age group due to estrogen deficiency. That also helps. And I find that in perimenopausal age group who are concerned with this dyspareunia, I think local estrogen creams like Evalon and all, that also helps, or estradiol tablets, 2 milligram tablets, that also helps. However, we need to rule out cardiovascular issues, LFT and all needs to be done in that age group, which is very common in that age group. And moreover, like I also add some soya isoflavones, phytoestrogens, so that they have a estrogen level maintained in the blood. That also helps in alleviating symptoms of dyspareunia due to vaginal dryness.
Yeah, absolutely. So the basically these lubricants are there, local estrogen therapy are there, testosterone can be, we are using specific steroid therapy, Tibolon we are using in case of menopausal ladies, or in case of like surgical menopausal, and it has a wonderful effect. I'm using SERMs. I have never used, but yes, people are said, those who are using, it has a good result. It's we can use the once a daily. So there are nowadays a lots of other procedure are there, lasers are there for the vaginal rejuvenations, but how effective the people, there is a big argument in there that many are saying this is only the cosmetic effect, it doesn't have much effect on the sexual dysfunction, but it's really a matter of research what to be told. The sexual these vaginal rejuvenation is only causes the functional, or it's only the cosmetic. So this is again a matter of defect. So what is the take home message? The sex health is an important for quality of life. The female sexual dysfunction is very common. Sexual functioning can be affected by illness, surgery, medication. Assess the medico, psycho, social, and relationship factor. Now it's included everything. So we have to find out each and every factor, assess each and everything. Simple history taking can do wonder. We have to ask about the male sexual dysfunction, treat the underlying cause if they're educate about the anatomy, physiology of the genital function, remove the myth and misconception, and treat the couple, not the individual. Now that is the take-home message. Thank you so much. I am really blessed to have such a wonderful panelist with us and such a wonderful, panel discussion with us.
I would like
So
to
thank
share
you so
one
much.
thing with you. Have you
Yeah.
ever had a patient with vaginismus? Because when I was in Kuwait, we were told that patient is a customer. And in a corporate care centers, they said the patient's desire has to be fulfilled. So one of our patient, a married couple, came for months together. They were not able to procreate. And the husband wanted a general anesthesia. It was in Kuwait, and it is a true story. Our anesthetist Bozidar, even the CEO consented, no, it has to be given. Poor man was sitting just outside the room, give little propofol, and thereafter the couple was fine. Somehow the things went uneventful. But one of case in my life, I was really laughing. How can it be?
Yeah,
That
definitely,
was
definitely,
given,
ma'am.
and it is a true story.
It's a true story. Ma'am, it is always said that the sex organ is not what is between the two legs. The sex organ is what is between the 2 ears. So it is many times what the upside, the hypothalamus, the brain, the psychotherapy has done such a thing which is can't be explained by anything we are just saying ki ye kya hai bhai. So absolutely, ma'am, there are, and we in fact we
But the
those who are
anesthetist
practicing.
poor
Yeah.
person, he was so upset. But because the CEO said that you will have to go through it, and he had to do, but somehow that patient remained all right thereafter.
Absolutely, absolutely, ma'am. Thank you so much, ma'am, for experience and for sharing this wonderful experience. Now, before I take a leave and say goodbye to all of you, just I want to share something. Is it visible?
Yeah.
Yeah, I am contesting for the chairperson, Sexual Medicine Committee, FOXY, and really I want your blessings, your support, so that I can spread my mission of sexual health for all, to reach each and every gynecologist, to reach each and every society, to give the basic, knowledge of how to identify this sexual dysfunction and how to treat them. So thank you so much to all of you, and please bless us. Please support me. Please vote me.
Sir,
Thank you so
100%.
much.
All the best for your next endeavor.
100% support.
Thank you so much.
Yeah.
Thank you so
Thank
much.
you,
So
Apurva.
before,
Thank you,
yeah,
ma'am.
thank you.
Sir, Padan
And
sir.
Yeah,
thank
it
you
was
so
very
much
nice.
to organizer, all the president and secretary of the 7 wonderful societies. Thank you so much to the chief guest, Padma Shri Dr. Usha Sharma ma'am, to the wonderful guest of honors, Ritu Khanna ma'am, Niharika ma'am, and Dr. Richa Sharma ma'am, to all the speakers, to all the panelists, and to all the chairperson. Thank you so much. Meet you again. And thank you so much, Corona Core Connect, for giving us the platform. Thank you so much, Vasisht ji.
Yes.
Thank you.
Thank you. All the
Thank you
best.
so much.
Thank you so much.
Yeah.
Thank you so much, Neeta ma'am.